Top Bed Talk.
Welcome to the third session at EBPOM USA 2022, the value proposition of perioperative care. I'm Desiree Chappell, your host. My co-host is Saul Aronson. Hello,
How are
Saul.
you, Desiree? What a fun, fulfilling sessions have we had so far?
Yeah, we've had some really great conversations. We want to continue that, Saul, with this session, the third session, defining a best case scenario for the post-operative value, which here at EBPOM, we have focused traditionally a lot on preoperative, intraoperative, and haven't done so much with post-op, have we?
We're going to tackle it right
now. Do it. So we have several guests with us today. First, we have Sam Ajizian.
Thanks, Desiree. Again, thanks for the opportunity. I'm Chief Medical Officer with Medtronic in the patient monitoring business. I'm a pediatric intensive care doc by training, and I've been with Medtronic in this role for about 7 years.
All right, great. Well, thank you for joining us. We also have Alan Kirk.
Yes, so my name's Alan Kirk. I'm a transplant surgeon, and I'm currently the Surgeon-in-Chief for the Duke Health System.
All right, so just down the road. Perfect. Yeah. And then joining us virtually is Melissa Cohen. Melissa, thank you so much. For everyone listening, tell us just a little bit more about yourself and your background.
My name is Melissa Cohen. I hail from Washington, D.C., where I've had roles specializing in implementing and designing value-based payment models.
All right.
I'm going to jump right in and throw a grenade in the room. Melissa, too bad you weren't here, but we had some really wonderful, dynamic, deep in thought conversations about value in an objective way, a monetizable, objective way, about how perioperative care can impact and is impacting preoperative and intraoperative sort of behaviors. We're now, going to spend some time talking about postoperative realities and behaviors. I'm going to ask our panelists to sort of just speak to how do cost pressures, reimbursement, payer dynamics influence the site of service choices that confront us today? And similarly, how do those site of service choices that we have to confront today impact quality and safety? Sam, I'm going to start with you.
Wow, starting with the device company guy. From a Medtronic level in our business, we're aware of the pressures and opportunities that are in the market now, shifting surgical and anesthesia care to different environments, right? And that's not just operative care, it is procedural sedation, anesthesia outside the OR. Those are economic forces, those are staffing forces, those are throughput forces. Some of these places are better suited for rapid throughput, for the right case mix. And we're trying to respond to those. We don't have any say in those, and they're different for every system, obviously, as we've talked about earlier today. Our most important job is to understand the shifts in the market and to be able to fill any technological gaps that are there. So as we see patients being cared for more in those environments, naturally, some of their postoperative stays are not in the hospital. They're straight to home. And we believe that there is a significant gap in monitoring opportunity at home. It goes from call me if you're doing this or that to, something that your family's got to keep track of. And occasionally we get some vital signs on patients if they're doing it at home. But really, in general, patients go off a cliff when they leave the PACU and head home in terms of monitoring capability. So as medical complexity and surgical complexity could increase in those settings, what are the opportunities to improve care while the patient's at home? So again, we come back to form factors around wearable technology that's connected, that gives you actionable, predictable data, not just a bunch of numbers, that provides value, picking up on trends earlier. So that would be sort of the way we're looking at the market now.
Alan, how is that affecting real-world decision-making, both through the lens of a surgeon, and answer that through the lens of a surgeon-in-chief looking at institutional dynamic?
Well, I think we're all on the same page that we should not be doing procedures in places that are unnecessarily complex or unnecessarily costly. And so the drive to move to less costly environments that are more appropriately set up for the procedures that are being done, that's a great trend. The challenge is we're trying to monitor for rare events, and building a system for a rare event is a challenge. And in the old days when we did a mastectomy or an appendectomy and you stayed in the hospital for a few days, when you had a complication, you had it in the hospital. And now you're not having it in the hospital anymore, you're having it at home. And so I think one of the clear things that we have to do as clinicians is find some way to get reliable data that's not encumbering the patient to do something, to come back so that you can start seeing when someone's going off the usual curve. And that's just math, really. You can see when people get 2 standard deviations off the mean of their pulse or their temperature, or, you don't have to have fancy stuff for that. And so I think that there's a lot of opportunity there. From a surgeon-in-chief standpoint and economic standpoint, payers just will not pay to have a procedure done in an environment that the payer does not think is an appropriate environment, whether we think it is or not. And it's really important to us to document why we're doing something in an environment that is hospital-based as opposed to ambulatory or procedure room, and to have dialogues, peer-to-peer dialogues with payers to make sure that the decisions that they're pushing on us are not unnecessarily pushing us into things we don't think are medically appropriate.
Melissa, through that payer lens, how do you reconcile those discussions, those differences of opinion when it is opinion, or disagreements of best decision or practice when it's not an opinion?
Tricky, right? And medical directors at payers have all kinds of different opinions about this. I would say that the move towards creating episode-based payments, especially in the surgical space, is really a move designed towards changing to lower acuity but appropriate sites of care for the purpose of reducing costs. So, the entire movement around creating those episode-based payments is in some fact driven by site of service, whether it's in the actual surgical or in the post-acute space. But all of the physicians in the room over there know that the way that care advances and learning, the regulatory and the payment and reimbursement landscape moves a lot more slowly. If you think about what's happening in telehealth and remote patient monitoring and all of that, it took a global pandemic for some of the rules around telehealth to be relaxed. So payers are moving in that direction, but sometimes it takes, CMS or some of the larger payers to make that first move for some of the smaller ones to follow suit.
One of the things that we see, there are, articles published every day in Becker's or whatever the, particular, if you will, reg journal you want to read, about how there's increasing, prevalence of doing an X or a Y or a Z. Spine surgery is the latest sort of example of that, in an ambulatory surgery unit, because we can, and there are instances where we can, but how do you know when we can? Is the question I think is really looming heavy on all of our minds right now, because the cost of being wrong is so real. And I would again, ask all of you to sort of speak to that through your points of view, which are the surgeon provider, the regulatory expert or payor, and industry who helps us make better choices. Alan.
Yeah, so a spine surgery, that's not a singular thing. There's lots of different spine surgeries, and the people you do it on is not a singular thing either. Patient is not like a single thing. And so you have to blend the different variables on the procedural side and the different variables on the resilience side. And I would argue, and we're really bad at this, the different variables on the social side as to what the right place for that patient is going to be. So 21-year-old athlete with a need for a spine decompression, who's got his parents staying with him and living in Bel Air, he'll be fine. Somebody that is staying on someone's couch and has the same injury, but it came about from a gang violence and they're 55, completely different thing. It'll show up as the same DRG though, right? It's the same procedure. And I think our inability to deal with the real complexity of what humans undergo is one of the fundamental problems. Again, there's a resilience definition that we have to come about, and there's good opportunities for data there. There are procedural complexities, but we really have to be thinking also about what someone's social resilience is, and we are just we're not good at that at all.
Melissa, how do you account, speaking as an expert in the industry of regulation and payor, how do you account for that? How should we account for that?
So I'd say a couple of things in this space. One is payers are historically very bad at making decisions or accounting for things that can't be found in a claim. If you're trying to figure out whether or not someone is eligible for XYZ, we're moving in the direction of potentially payers and providers having some sort of bi-directional data exchange, but that's still a long ways off. So much of it is claims-based, and that really doesn't capture all the information that we were just speaking about. So, to the extent that some of these new things want to be tried, the suggestion that I would make, and what I did when I was at Anthem Blue Cross Blue Shield again and again, was pilot programs. So working with one particular hospital or IDN, talking through who the eligible patient population is, starting very small, developing ways for that data to be exchanged, and then having some sort of either quality performance metric or risk associated with to make the payer feel comfortable that they're wading into the space. But pilots are a really effective way of working with payers to get them to at least dip their toe into that space.
Sam, to skate where the puck is going, clearly this is where the puck's going. How does industry position themselves to be an advocate of change that makes sense?
Yeah, I think it's understanding the voice of our customers, which we're hearing today, but also understanding that voice comes in a myriad of different flavors, if you will. And again, the theme here at our company is to pull back to a macro level and find solutions that can work as you're piloting a knee scope program or you're piloting spine surgery in an ASC. What are the common gaps there, and how can we help you improve workflow, patient safety, and hopefully drive some revenue as well, or significant cost savings around patients not coming back to the ED and intervening earlier. It's challenging intraoperatively in those spaces. We'll set that aside. I think that's a different conversation. But outside, it comes down to this lack of data. And to Alan's point earlier, we don't want to turn every post-op knee scope into an ICU patient with continuous monitoring that's generating all kinds of numbers during the night. We have to realize that monitoring the unmonitored, which is what we're talking about now, can be done in a lot of different ways with hands-off, properly connected technology that picks up trends earlier. And it really is about math, as Alan said. As the devices evolve and patients wear them longer, their own trends will become apparent within the device algorithms, and personalized reactions will happen earlier instead of population-based. And that's the end of it's the end of the game as far as I can see it now. I don't know where we'll go after that. So lots of opportunity there. I think resonant for cost savings, resonant for revenue, resonant to prevent serious complications that instead of happening at midnight with a resident there, are happening at home with our mom there, and a lot of opportunity around that with the right tech.
I'm going to bring Dr. Phillips in, has a question.
Karen Phillips, I'm the Chief Medical Officer for the Respiratory Interventions Group at Medtronic. There seems to be a disconnect, to my mind, between what is being asked of us as clinicians and us as medical device companies in order to improve our patients' outcomes and values, to assign value to devices that bring better outcomes, and as clinicians we're being pushed to practice better for better outcomes. Yet, it would seem that the review process for reimbursement seems to lag a little bit behind, and there may be some areas where it is impossible for us to truly realize that value because it ultimately makes no difference to the payer. I'll give you an example. If a patient is intubated for 5 days, there's a payment, but there is a perverse incentive to tracheostomize them earlier. How do we as industry and clinicians encourage CMS and others to be a little bit more progressive in their reimbursement scheduling?
Melissa, I'll let you as a policy wonk.
That's yours, Melissa.
Goodness. I did just mention that the policies and the reimbursement schedules seem to lag a little bit behind the innovations, and it did take a public health emergency to change some of the telehealth rules that I think everyone could have seen a long ways off that made a lot of sense. One of the biggest issues with CMS is fraud and abuse, right? And the Office of the Inspector General is really concerned about Medicare fraud and overuse. So again, I would have to say pilot programs, like some sort of proposed model through either ACOs that are taking risks and therefore have different incentives, or, a pilot program in and of itself. But the reason that CMS, it's taken quite a long time for them to put forth these remote patient monitoring codes. And a lot of that has to do with fear of overutilization and the inability to actually restrain spending. So I think, and that's one area. The second I would say is just a lack of understanding, right? You have a lot of civil servants that don't necessarily have a lot of access to some of the new innovations that are happening. So the more that you can educate and the more that you can propose sort of research and literature that demonstrate the effects that this type of reimbursement will have without increasing spending and preventing solvency of the Medicare Trust Fund, the better. So I think CMS is open to those kinds of conversations, but it does take a really long time. It's, much slower than private industry.
Are there lessons to be learned from some of the pre-op things that are going on? We talked, Bobby Jean was talking, Dr. Schweitzer was talking a lot about looking at, the social piece of that and then getting reimbursements in those. And Dr. Schweitzer, I was just wanting to know if you had any comments on that, because I think there may be some lessons to take away.
Speechless first. I think pre-op has always been sort of the stepchild of perioperative care. So to think that we can maybe have some lessons to learn from what we do in pre-op for the rest of it, I think, yes. First off, I think it would be wonderful to have some data, and we talked about earlier today, for patients coming in, and that best data is from their homes, right? We know that ambulatory blood pressure measurements is the gold standard, and nobody should be diagnosed with hypertension, or very few people should be diagnosed with hypertension without the benefit of having ambulatory blood pressure readings. And yet we're just completely backwards in that, right? So I just think that, there's so much we know already about physiology and science and medicine that we just is not keeping up with what we actually practice and do. I always say the only thing that's worse than no data is bad data. So I think it is important that we, are careful about how we start to develop these tools to get data, and we know how to use that data and use it wisely. And I think AI will hopefully help us with some of that as well, because I think we can't rely on manpower and people to continue doing a lot of the care that we also deliver, right? Mm-hmm. And I think, partnering with patients too. In fact, I jokingly say, actually, you're probably better off to be at home after surgery where you're near someone who cares about you than on a surgical ward somewhere. And I'm not sure we don't need good continuous data coming from this patients are hospitalized. I think, you go from sort of no care to ICU care. Some of the ward care is almost like no care. And so it's just really a ripe opportunity for us to think about personalizing the care so that we're triaging the right care to the right patients. And a lot of it, when we have to start with defining of what we really think is quality and value added. And
so the confluence of these realities, look, we're broke. Let's just lay that out there. The cost of healthcare is not sustainable in our current trajectory, whoever the payer may be. And so we're realizing that, we're confronting that, and we're doing some disruptive things to address that, including trying to figure out where's the best place to have your surgery. All appropriate. But, or in addition, we're having an increased aging population. We're having an increased realization of the disparities in the delivery of healthcare for the, underserved populations. We're having an increase in the insurgence of patients weighing in on their expectations. And we have chronic disease management gaps that we're now appreciating need to be addressed. They're not aligned necessarily, and yet we have to resolve that. And how do we do that best, is the challenge. One of the things that I would just sort of share with you that I've heard is the common thread is the patients need to be more involved. They have to be more invested in helping us understand and define their needs. But how do we as healthcare providers teach them that's their responsibility in this, if you will, deliverable? Alan, as the provider, how do we do that? As a surgeon who's got that uniquely important connectivity to the patient who just confronted the need for surgery, how should we change our behavior?
I come from a unique specialty, transplantation, where there is a long-standing pre, peri, post, rest of your life relationship that you deal with, which is different than somebody that's, not a judgment statement, but doing a knee or doing a hip or something like that. But
don't worry, 2 million people are listening.
That's fine. Not a value thing. But the regardless of how much you interface with your patient, whether it's going to be the rest of their life or it's just going to be for 90 minutes, you do have to have that sit-down conversation with them and get them invested in it in a way that you, through your interaction, feel is going to be effective for them. There's not a single way to do it. Sometimes you can, pull on someone's heartstrings. For a transplant surgeon, it's, think of the donor that has given you this. You really need to protect that.
Right.
But there's, you have to figure out through some sort of humanistic relationship with your patient to get them involved. And there's a skill to that. I think clinicians that do better have figured out that skill. And it's not that they're necessarily faster surgeons or, have had their hands touched by God or something like that. It is that they've gotten to their patients in a way that they're partnering on this. And if you come around the wards in the morning, you can tell who's had that conversation by who's out of bed. Did you tell them, tomorrow, you got to get out of bed. That's your job. That your job tomorrow, get out of bed. And they will. If you don't say that, how would they know, right? They hurt, they want to stay in bed. So I think communication, which you don't bill for really, and it doesn't really cost anything.
Yes.
It's very, very effective.
How do you teach that?
Yeah. Well, surgeons have always been known for their skills in communicating with people. So, I think the good surgeons are good communicators, and we have to go into residency programs and medical schools and make sure they know that that's as important as any medication that we're giving somebody. And that skill set has gotten lost in the hustle and bustle in the high-tech world. It's very clear that AI as a standalone will always fail. AI as an adjunct with the clinician will be super powerful. And we're trying to figure that out.
Yeah.
So I just had an epiphany. I think maybe, so talking about, learning from others, I think learning from how we manage, or you guys manage transplant patients, right? There's that long sort of relationship building. It's a team approach. It's really clear I think you guys make it clear to the patients that there's a precious resource that they're going to, a limited resource. Not that it's open-ended. You can get another knee, you can get another this, if this, and that they have an obligation to do certain things. So that if they don't stop drinking, they don't get a liver. If they don't stop certain things, right? If they don't have the social supports to support getting a transplant, right? So maybe we just need to take a lot of the stuff that you guys have been doing for the last 20, 30, 40 years and push that over into every surgical.
Well, I think that transplanters have always been doing perioperative medicine and multidisciplinary care. It's always been that way. We just didn't call it that, right? Personalized medicine. I mean, just the cross-match, which you do before every transplant, tells you whether they're going to have an immediate catastrophic complication or not, and whether you do the case or not. So we have biomarkers, and we know how to use them, but spinning that out into more commodity-based care is very, very challenging.
True.
Yeah.
Is it, or we just never tried it, or we haven't decided that that is a priority of ours, or that there are not incentives built into doing that?
Yeah, well, it's not prohibitively complicated, But it is harder, I think, because again, you have to make a cultural change in that.
So Melissa, it's not claims-based. Obviously, this is a really important conversation. But how do we translate this conversation into policy or a language that a payer can track, measure, reward, or penalize, if you will, by behavior of compliance? It's a ethereal question, I know, but I would love to hear your opinions on that.
Well, I do think that the patient voice is something that has been tragically missing from the value movement. The value-based care movement has been seen as an effort to improve quality and cost and patient experience, but it's predominantly been a contract between a provider and a payer. In the interest of trying to make it patient-focused, there have been requirements around putting a patient on the governing body of the organization or having a CAP survey or something to that effect. But I think we've lost the thread somewhere because the definition of value in the way that are currently measuring it as, APM or alternative payment model revenue flowing through provider contracts is not necessarily translating into patient value. So I think it's exactly right that we need to be asking the patients, what they need and educating the patients about what we're trying to do in terms of coordinating care and improving the quality that they're receiving. In terms of sort of compensating or building in some of those things, payers have tried, right? I mean, CMS now has this care coordination metric, but it's very complicated. There are all kinds of sequelae that come out of patient experience metrics, unintended consequences, and all of that. So trying to be able to measure how well physicians work together on team-based care and actually incentivizing or paying out as a result of that, we really haven't solved that yet. I mean, some of the things that have been done have been in the way of investment dollars for infrastructure around care transformation and hiring of care navigators and sort of milestones around practice progressions towards that. But in terms of quality metrics or ways that you could incentivize this type of care transformation or shift, the jury's still out on what works. But you basically could say that for all types of quality metrics, right? Unless you're measuring, glucose levels or something, which even that is sort of, those metrics change too. But I think similar to a lot of quality metric science, actually measuring care transformation and providing incentives for better education and cooperation is still a hard nut to crack. I mean, we've moved away from a lot of metrics around shared decision making. That was one thing that was tried. And I think CMS is still, they just recently put out a proposed rule last week, the 2023 physician fee schedule, in which they asked for requests for information on some of these exact same things. So, yeah.
Sorry, one more. I just wanted to kind of piggyback on what Bobby Jean said. I'm Steve Garvin. I'm a colleague of Desiree's in Louisville, Kentucky. And I mentioned this to Sam earlier as well, is we do actually have a similar or a model that gets patient engagement prior to surgery, which is the parturian, who really invests in their preoperative course. And my question is that, could we draw a parallel between those 9 months and what maybe we would do for this episode? Is there anything we can draw from that experience?
I don't know that answer, though. I love the analogy, and I think we have to figure that out. Here's what I'm thinking as we're talking to each other, because this is laudable stuff, man. But here's reality. We're built. Real estate is a great place to be right now because we can't build enough surgery centers. That's everybody's investing in and building more. There's huge capital being spent on that dimension of care. Most institutions, if they survived, are now at 110, 120% capacity, and so there's not enough beds in the hospital traditional settings anymore. And so, it still is a business. It's a compassionate business, but it's a business. How do we align, these conversations about being better advocates of patient care and engaging patient input with the fact that we got to fill those beds, man, or we're going to not be able to pay the rent?
There's never going to be a shortage of patients. The population is growing at a rate that we cannot keep up with. So it will never be a problem that there won't be enough patients, at least in our lifetime, right? So all of the concerns about filling the beds, I don't think those are real concerns. There's just tons of people out there that need care. We just have to stick to simple things, and the simplest is the best way to do things, the least expensive way to do things is to do them once correctly. And if you can do that, no matter how you do it, you're going to win. Your patient will be better. It'll cost you less doing things once correctly. And I think this whole discussion of the pre-op optimization, the intra-op optimization, the post-op, it's all about trying to make the right decision with multiple dimensions of data at each node of that. And we should, I think, move away from trying to talk about things that are economically feasible and just get to good decision making from a biological standpoint, a pragmatic standpoint, an ethical standpoint, a social standpoint. Find some way to link all those things together to at each time we see a patient, we're making the right decision for them.
So Josh spoke to earlier, and I think he was very honest, and he made a really good point about he still is working with a number of surgeons today who want to fill their blocks with, surgical care. They're less concerned about the fact that the patient's anemic or their A1C is high. Yeah. They just want to, sorry, orthopedic people who are listening on the podcast, do the knee replacement. Yeah. And we have to find a way to balance these realities. And we're searching for best practice combined with best policy, combined with utilization of best technologies. And so I don't want to get too, philosophic here, but golly, how do we do that and not ignore the realities of the world we live in today?
You put surgeons on salary. That's how you do it.
I mean, absolutely.
If you go to the military has great surgeons, great orthopedic surgeons, great transplant surgeons. They don't get paid a single dime more or less based on what they do. They're great surgeons. They work hard. It works in the United States and all of a sudden we think that when they step out of that role, that somehow they're going to be less moral people. I mean, we may make them that way, but you put surgeons on salary, most of this stuff goes away.
That's pretty provocative, and having been in the military myself, I couldn't agree with you more. There's a vast difference between practice in the active duty military hospitals and outside. And I think it's really, we're victims of our economic model here in the United States. We really are. I mean, we're incentivized for throughput and volume, right, in the operative world. And so until those fundamental things change, you're not going to have time in between your knee cases to go and spend 5 minutes with that person after they've completely emerged from anesthesia, by the way. How many times do you see those conversations happening when the patient is still not even awake and not going to remember anything? The first week of medical school, my introduction to clinical medicine instructor taught us the difference between a good doctor and a great doctor is one thing. It's time. If you have more time to spend with your patients, you'll do a better job. That stuck with me, like week one. And all I've seen in my career, and all of us, is the erosion of that ability to spend time with our patients, do the communication that some specialties have the luxury to do, like Alan's, like mine in critical care, where I've got the luxury of time all night to sit and talk to people. That's eroded in the operating room. It's just volume-based, and we've got to find a way to fix that.
So, Sam, how do we manage that reality? These are great points, and we should have them be indelibly, tattooed in our minds. But in addition, we're in a crisis of staff shortages right now.
Right.
So even though we want to spend more time, even though we want to do more, we are stretched probably beyond our capacity. So where does the preoperative optimization, where does the intraoperative utilization of tools and technologies that make us better, where do our decision-making skills for postoperative disposition intersect in that context? And again, it's a very high-level rhetoric question, but how do we force the issue? If we wait for policy, Melissa, it's too long. So we have to drag policy to success. How do we do that as providers? How do we do that as the first-line providers?
You know, if people were on salary, it'd fix itself. It just would. I mean, that sounds too simplistic. But, you know, the reason people are trying to push through cases that shouldn't be done, trying to get them onto the schedule quickly before their glucose is fixed or their anemia is solely economic. It's not that they don't like people with anemia or they don't care about it. They just, that's how they're making their living. That's how they've been taught to make their living. And if you taught them that you can operate on them when they're ready and that they'll be fine and you'll be able to send your kids to school, most of that behavior would go away, I think.
I feel like in institutions where I've been, most of the surgeons are actually salaried. I mean, they're part of the organization. They're hospital owned.
Yeah.
And I still feel like there's a bit of competition. There's always the threat that they may leave and go start their ASC, and things like that. And I don't know, I feel like that's creeping in a little bit.
Yeah.
Even if you're on salary because you're employed, you're not on salary because you're incentivized by how many,
you get.
You have an X plus
there's
Y
a
plus Z.
productivity,
Yes. Yes.
So with all due respect, Alan, I'm going to reject that as the solution because that ain't going to happen in our lifetime.
It's a solution, but not a pragmatic one for sure.
Yeah.
Right.
Yeah.
Sure. But the drive to get cases on before they're ready is a behavioral problem that is where most of the expense of surgery comes from. I mean, most of the expense of surgery comes from a very small fraction of people that either shouldn't have had that operation because they were not resilient enough to undergo it or didn't need the operation. If you could scoop 5% of the cases off, maybe a little off with my numbers, but 5% of the cases that really shouldn't have been done or were done prematurely off, you would take 25% of the cost off of operative medicine, I think.
Bobby?
Yeah, I mean, thanks for saying about not doing cases. I mean, I think we know there's data that a substantial amount of surgery services, and in fact, even medical services, have no added value to patients. So it's not just that the patients are too high risk; it's they shouldn't even be having surgery at all.
Yeah.
And I always think it's kind of interesting that I rarely ever take care of a physician in the operating room unless they're having cancer surgeries or something like that. They're not having knee arthroscopies and shoulder arthroscopies and, plastic surgeries. And I think a lot of the rush to sort of do surgery, too, is that before the patient gets well on their own. People talk about, the queues in, other countries. Well, some of that is a nicely built-in queue so the patient who's back strain or their ruptured disc is causing some pain right now will be better in 2 months, whether they have surgery or they don't have surgery. But we do surgery, and we've incentivized patients to think that surgery is always the better option that they're given.
I think that that's really a critical point, is that we have built expectations of surgeons of certain surgeries being cures to very complicated problems. And so of course they want surgery because they're going to get fixed. Back pain's a good example of that, where the most common risk factor for a back surgery is having a prior back surgery. So there are expectations with what patients are led to believe about the efficacy of certain procedures that has to get addressed. And payment models is one way to, policy-wise, to try to change those things. The problem is when you make global policies, it always breaks down at the granularity, and that's really hard. I mean, it's not that the policy lever is a bad lever, but it can only be but so granular.
Melissa?
That's right. And that's why what you've seen is sort of a migration away from some of these specialty-focused models. Folks have been trying to master the oncology model or the kidney model or the, any sort of acute episode model or chronic care bundle type thing. And the more that time passes, I think they've started shifting more and more towards some sort of total cost of care or global budget, and then leaving it to the individual healthcare organizations and their unique situations to contract downstream with providers to be able to effectuate the results that they're trying to see because of all of these unique scenarios with, different geographies and different access and different makeups of providers. So, I think we'll see how that ends up working, but I don't think you're going to see a lot more specialty models coming out of CMS or potentially in the commercial space because they seem to follow suit on that. There's going to be more of a focus on these total cost of care models with some, addition of quality metrics and some guidance on how to potentially engage specialists or contract downstream, maybe some rules around engaging other specialists or new codes around care coordination or behavioral health integration, those types of things. But because of the very reasons you stated about how it really breaks down when you try to make policy at the granular level, they're trying to zoom out a little bit.
So there are two keys to that are attribution and longevity. It's very difficult to have a total cost of care model when you really can't attribute a life to a set enclosed group, and that's very, very challenging right now. And then people move, and so you can do everything you can to make sure that the 1 year outcome of a surgery patient is great, and then fall off a cliff in the second year, but you don't care because now you know that 80% of your people are in another plan then. And so those are the two challenges that need to be done. And in our country, which is really a third world country when it comes to health policy, not having a single payer solution for patients makes those two things, which are important, very difficult to do.
So we actually do have someone who works in that system.
A lot of those, and that's why you're seeing a lot more of this type of experimentation in the traditional Medicare fee-for-service population that has significantly less churn than commercial or Medicaid. It's much more difficult to do with those payers.
Yeah.
Monty, I'd love your perspective on this.
Well, I mean, having worked in a number of different healthcare systems around the world, including the US one, I would say that the national healthcare system in the UK is the worst healthcare system apart from all the others.
Yeah.
Thanks.
So I'm going to ask us to just come back to the pragmatic. I don't look. It may be that we'll evolve to a single payer, and maybe in my lifetime, maybe not. I think it's more likely that than
salary.
We'll have all our surgeons be on salary and not have productivity incentives. I think we are in the here and now. I think it is what it is. And I think what we're realizing is that there's a lot of things that we could do, should do, that will help patients tolerate the stress, the perturbation of this unnatural insult to their bodies. And when those things are done proactively, they're more likely to tolerate. Yeah. And that's a good thing. Yeah. What we're learning is that there's actually value in a business case sense, as well as value in a patient-centric quality of care sense. Those are the data. Now we have to figure out how to translate that into practical, everyday life, and realizing that we live in a life where there are incentivizations to do stuff. And the more stuff you do, the more income you generate. And that's as equally true for institutions as it is for providers. So that's my world, and I'm accepting that as the foundational truth. My question then is, or my comment is, how do we interdigitate these two truths? And I think that's the immediate answer. I don't know what the midterm or long-term answer, but I think that's the immediate answer. And I don't think we're doing that well at all. So how do we do that for the immediate next step, Alan Kirk?
Well, I think that what we have done in our institution is we have developed a good relationship between our anesthesiologists and our surgeons. Our past clinic model, which you helped establish, has developed a general acceptance that patients should be considered for mitigatable risk before they undergo surgery. And most surgeons are okay if they hear back and say, we need a little extra time to get the glucose fix, not always. 80% of people don't really have a big mitigatable risk and they just go right through. And I think that's been one of the ways that's made it work, is that the whole process has actually gone faster by recognizing you have to slow down about 20% of people. And so once the surgeons recognized that actually it didn't slow things down, it just helped call out the people that really needed work, I think that has helped us quite a bit. I mean, you drop in the middle of that a pandemic and a global nursing shortage, who knows why things are happening right now. Yeah. But I will say that we're getting much better at accepting that some people shouldn't have surgery yet, and maybe and we can make them better in the future, and that is moving in the right direction.
How do you translate that in a franchisable way?
Yeah. There are certain groups that are big enough and well-to-do enough that they have the expertise and they're not going to be influenceable by, external pressures. They're going to have to learn it on their own. But I think there's a huge swath of American medicine that doesn't have the resources to do that. And if you gave them a value proposition to help them and took risk in that too. So you're not saying, we'll come and do this and you pay us this amount of money, but you come and say, look, we'll come and do this and we'll bill for what we can bill. You don't pay us anything. We'll deliver you better patients in the end. I think that model will work.
How do you get payers to buy into that frame of reference? Melissa, how do you get industry to be sensitized to that frame of reference? Sam, audience, how do you get your surgeons at your local places of practice to embrace that frame of reference? So, Melissa, you first.
I would say that it comes back to data. To the extent that the data is out there, that this delivers better patient outcomes, and that it does, in fact, reduce costs. This is something, the readmissions measure is one of the most highly looked at measures that's used for all quality programs and payment, paper performance incentives, all of that. To the extent that you can demonstrate that the clinical care model actually reduces readmissions, improves outcomes, I think that's something that a payer will look at and actually want to figure out how to create, a reimbursement model around. And I would go back to the idea of piloting, because especially the big payers, they are willing, if they have an innovation shop, they will be willing to do some sort of pilot. Yeah.
Sam, real quick, what's industry's sensitivities to this kind of conversation thread?
Yeah, we're right there with you. We're right there with you. We hear you loud and clear. All the things that we've talked about today, there's one thing we left out. We spend more on a healthcare dollar in the U.S. on the administration around it, getting the paperwork pushed around, getting all the I's dotted and T's crossed than any other country in the world, right? So what can industry do to help that part of the equation as well? When you roll into the OR and there's 5 people that all of a sudden somebody will run to the computer and start entering things that could be automated with the right technology on the patient. So we need to think about patients flowing through our system, the administrative wake of work that creates, and how can devices help solve for these repetitive administrative kind of things that accompany the patient. That can aid in billing in terms of proper OR time, entry and exit. It can help with throughput and patient management throughout the departments, and can do a lot of other things that we haven't even talked about today. Some of those things are done by us typing away, and that keyboard time erodes the ability to talk to our patients. So there's a lot of convergence here with the right technology, but we hear you loud and clear. And the key is having medical grade, price friendly, form factor friendly, deeply connected tech rather than something that's not, because that won't move the needle. So we hear you, and it's being worked on.
On that note, we want to thank our guests. Melissa, thank you so much for taking the time out. We know how much of a stressor it is. We've all been there before and done this virtual thing for way too long. Hopefully next time we can see you in person, but do take care, and thank you so much. Alan, Sam, thank you very much for joining us in person. It's been a fabulous conversation. Saul, great questions today, great sessions. Thanks again.
Thanks, everybody.
Fantastic.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.